fine. So can work this? Okay. All right. Yeah. Okay. All right. Okay. Bismillahirrahmanirrahim. If we can get started now. પહેલાં તો મુફદ્દલ મૌલાનો એહસાન અને અઝીમ છે કે આપણે સગલા અહીંયા જમે થયા છે ને એનો શુકર કરું છું કે મને આ મોકો મળ્યો છે કે I can impart a little bit of idea about obstructive sleep apnea. So let's start off with a question, right? What is everybody's understanding? How many of us think that obstructive sleep apnea is a disease? Show of hands. Okay. How many of us think it is a mechanical obstruction? All right. So those of us who think it's a mechanical obstruction win, okay? But then again, this particular condition, which is a mechanical obstruction, will create a domino effect that will cause all kinds of diseases. So it is a little bit of a wake-up call that we don't necessarily think of sleep apnea as a condition whereby anything else will be affected. So I don't sleep too well, or I snore, so deal with it kind of thing. But it actually has long-term, short-term as well as long-term implications on your general health. So let's start with a few questions. And I would love it if we get all interactive about this, because otherwise I intend to put you to sleep with this talk, okay? And that in itself will be a stress test to see how many of us need a sleep study, all right? Okay. So the first question, which of these accessories actually saves lives? Some of us might say Apple Watch, right? But so far we don't have randomized control trials to prove that point. All right, so it's CPAP. The estimated prevalence of OSA in middle-aged men and women is approximately how much? See, exactly, 34% in men, 17% in females. And that in females rises up postmenopausally. Which symptom is most characteristic of sleep apnea? See, all right. The association between sleep apnea and atrial fibrillation is most strongly mediated by? It's actually A. And the reason it is that, and we'll talk about it later, we are breathing, or we are making respiratory effort against a closed upper airway. So that causes massive intrathoracic pressure swings that leads to this condition. Dr. Gadiali spoke about this, so I'll just quickly test everybody who's awake in his lecture. All right. B, all right. Dr. Gadiali, you win. All right, okay. Which factor is most predictive of long-term CPAP adherence? B. And it is remarkable, and how quickly there is an improvement in the entire symptomatology as well as perception once a patient sleeps on a CPAP machine and who has been dealing with symptoms of sleep apnea for months and years at a time, and then all of a sudden 2-3 days a week, and boom, they are good. They are like coming to your clinic and they are like, you have done the best thing possible that I could have. I actually slept. And what is the one thing do you think that they say that they did now that they slept while during sleep? Dream. They lost their dreams for the longest period of time. You ask anybody who has bad sleep apnea, they don't dream. And the moment they sleep with CPAP on, they start dreaming. Now what they dream is a whole different conversation. All right, so the learning objectives. By the time I finish, let's see how many of you do need a sleep study. But in any case, key symptoms, risk factors, what are the multi-system consequences of untreated sleep apnea, get into the diagnostic approaches towards it, and how other specialties, especially our dental colleagues, can help determine who needs to be studied for sleep apnea. And then we'll look at some treatment options. I will, of course, pay more attention towards the medical side of it. Dr. Gadiali spoke about the surgical side. All right, who has done this? And told them the next morning what the heck was going on last night? Yes, we have done this. Some of us have done this. We have objective proof that our spouses, and I would be the first person to say that it is the guys, right? The women don't have this much of a problem. So you can raise up a storm with your snoring, and the main person affected is your bed partner, right? So they are the ones who are basically have lost their sleep as well at the same time. So snoring is actually the airway crying for help. It is asking you to look at it and try to fix the problem. So snoring is not, it may be considered to be benign by most of us, but it's not. So what on earth is OSA? So we are dealing with a recurrent upper airway collapse during sleep. And while that is happening, the airway gets closed, mechanical obstruction, the lungs can't get air in, desaturations happen, carbon dioxide can't get out, hypercapnia happens. Those two things are the main drivers of brain stimulation in terms of waking up, because the brain thinks you're about to die. Because you're not getting oxygen in, you're not getting carbon dioxide out, you need to wake up and breathe. So the brain never goes to sleep. You think you're sleeping, your brain is not sleeping. It's constantly trying to keep you alive till the next day, all right? So as we talked about, 34% in adult males, 17%. For the most part, remains undiagnosed. We have a very high percentage of patients who are undiagnosed, especially in our community as well. I do a little bit of screening around Ashura time and during Sharullah, and I got a few people endorsing all these symptoms. Risks, again, obesity being the most of it, but that does not preclude people who are thin. It is not about how big you are down here. It is about how big you are down up here or how small you are up here. So it is an incorrect assumption that thin people will not have sleep apnea. They do have sleep apnea. Dentist and Dr. My Hamnam as well, Dr. Mogri will tell you that he must have sent a few people in his career to sleep studies. All right, so I already went through this. I described the first two. The third one, now that the brain is panicking, it is causing a sympathetic stimulation to the entire system, right? So now your heart rate is jacking up, your blood pressure is going through the roof, and then your airway opens up, and the brain says, okay, fine, problem solved, let's go back to sleep. So you go back to sleep, and it's only until that airway collapses again, and this whole cycle repeats again, all right? And this cycle is constantly repeating through the entire course of the night. So when you wake up in the morning, why am I so tired? What the heck happened? I slept 8 hours. Next night you try to sleep 10 hours. Maybe the other 2 hours will help. You are even more tired, right? So this feeling that I am constantly tired is one of the main symptoms that patients present with. So let's look at the anatomy. And so this is the oral upper airway in a normal person, right? So you're talking about this area right here. See how patent it is, the retropalatal region and the retroglossal region? This is your patent airway, and if you have this going on through the course of the night, you're golden, right? But now you have 4 pathological conditions where you have either an elongated soft palate, so it is narrowing you up here. You have increased tongue fat and inferior hyoid position, which is further narrowing you. You have a mandible that is retrognathic, so it kind of pushes back. You get certain critical areas of narrowing over there. And then if you're really gaining weight, then at the back, the posterior wall really starts building a lot of soft tissue, thereby reducing the circumferential area as well. So these are the possible pathophys, rather anatomical reasons why the upper airway is compromised. So symptoms we all know. The main one being excessive daytime sleepiness, and we'll describe that a little later when we look at how we objectively assess that. Morning headaches, memory impairment. In memory impairment, what is the main way that they manifest that? So it's not about they can't do math questions or they don't know how to maintain their checkbook. It is about they are talking to you and they lose their train of thought. And they're like, oh, hold on, what was I saying again? So that is another clue that they just cannot, they have these memory lapses, concentration difficulties, like a brain fog moment, right? So those are the subtle symptoms that you would encounter with them. Another big one is nocturia. Now, anybody who never woke up during the course of the night, or maybe at best one time, now is going 4 to 5 times during the night to the bathroom. Why is that happening, right? So that, because it happens over time and happens slowly, people shrug it off and say, hey, it's old age, I have to go at night. That's not old age. You are showing symptoms that maybe, and then you're tired in the morning, and then you are sleepy during the day, and he's taking 2, 3 naps again. So all these is adding up. But unfortunately, we don't, or rather patients do not put that together to say that, hey, this is following in a classical OSA pattern, right? Dr. Gadiali talked about the Malampati class, so I will not touch it there. Examination findings, for the most part, obesity, neck circumference is big, Malampati class is 3 and above, and then if they have any structural changes to their head and neck. So now let's switch gears and get into the multi-system fallout, right? So how are we, what else is getting affected? So the biggest one is the cardiovascular system, right? So every apnea, or every time you are holding your breath during sleep, you're stressing your heart. So if you don't know wake up with chest pain, your heart is good so far. Otherwise, because you were stress tested the whole night, right? So what are the consequences as a result? Long-term, high blood pressure, atrial fibrillation, heart attack, stroke. The way I describe it to my patients is, your brain is telling you that if you do not let me go to sleep, I'll mess up all your other organs. It's as simple as that, right? So when you say it that way, it kind of wakes them up that, hey, I'm not taking care of my sleep, I'm not taking care of my brain, which is not sleeping, and the brain will take everything down with it. So this has been well proven as well. Cardiovascular mortality goes up in patients whose AHI is more than 30, which puts them in the severe category. Their hazard ratio is 2.25. So that is a pure and simple way of saying to them, you don't treat your sleep apnea, you are going to prematurely die because of cardiovascular event. As simple as that. And then these are the drivers that cause that. Now, the brain fog I alluded to already. What was I saying? I don't remember that conversation. All these subtle cognitive deficits starts to appear. And especially in patients who are 60 and older, they start talking, okay, tane to dementia thiru chhe yaar. Like, na bhai dementia ji nathi thayu, bhai mane sleep apnea chhe khali. All right? So depression, mood swings, irritability. बड़ी वाट भी वाट अंदर चिड़चिड़ा थी गया बड़ा कि भाई मम्मा तो एकदम चिड़चिड़ा है बाज के मतलब अब्बा ने गुस्सा भी है घड़ी घड़ी वाट में. All these are subtle things, right? All right. So you are eating a donut every night, whether you like it or not. Okay, you are getting hyperglycemic, and that's without actually putting a donut in your mouth. So type 2 diabetes, the metabolic syndrome, weight gain, everything is happening while you're sleeping because it's all because of the brain not sleeping. Same thing, you wake up fatigued, you are tired all the time, you don't want to exercise, you gain more weight, and that vicious circle just keeps perpetuating over time. Hormone havoc hour, again, belly fat, decreased testosterone, decreased marriage satisfaction, PCOS association in women, thyroid problems. So basically, bottom line, everything is going down. So I alluded to this already. So this is now amplified in our South Asian population. And these are the main reasons. We have a higher incidence of diabetes, higher incidence of undiagnosed hypertension. We have a insulin resistance that is happening, as we heard in the talk this morning, at a lower BMI. And then, सबसे मुट्ठी बात जो अपना community में है, ignore. નથી કરવાનું, નથી કંઈ નથી મને કંઈ નથી, રેવા દે કંઈ નથી કરવાનું. That is the biggest thing, stigma, all right? રેવા દે કાલે સુઈ જઈશ વાળા, you know. તો લાઈક એ સ્પેશિયલી આપણા બૈરાઓમાં તો છે જ 100%. આખો રાત જાગતા હશે, ઇન્સ્ટાગ્રામના રીલ્સ આવતા હશે રાતના 2 વાગે. મેં કે તમે છૂટા કેમ નથી અમ્મા હજી તક? ના બેટા હજી ઊંઘ નહોતી આવી. ઊંઘ શું કામ નથી આવી? કેમ છે આ બધું? તો આખી સાયકલ શું કહેવાય એ લોકોએ બિગાડી કરેલી છે, ડે નાઇટ સાયકલ, રાઈટ? એન્ડ દેન and some of them do have significant sleep apnea that they just are not telling us. So punchline, it will cost you your health. If you have work issues at work, it will cost you your job, and then somebody is going to kick you out of your bed. So you will be sleeping in another bedroom because that person who's not sleeping next to you because of your snoring is not going to like it after a few nights, right? So it is extremely. So what is the gist of this whole story? We have to recognize all these subtle findings of sleep apnea. Dr. Aliasgar Mogri will tell you that he sees this all the time in patients. We have sleep apnea, scalloped tongue, large uvula, mandible that is kind of pushed back, malocclusion, enamel has worn out. So he is in a very good place to screen these patients. And these are actually he's the gatekeeper, so to speak, to refer patients for OSA testing. કેટલું થાય છે તમારે? How often do you see such things? Mm-hmm.
Sometimes it's not direct. You don't realize what it is, or not accepted of that. When you talk about goals in place, possibilities of sleep apnea, it's suggested to them because they actually follow up or do it. Sometimes the case because you think that it's not particularly.
Mm-hmm. Yeah. But તમારો પેલો pathway નથી બનેલો ને એનો કોઈ સ્લીપ સ્ટડી કરાવવાનો ને સગલો. Yeah. Because you would tell them to go to their PCP, right?
Yeah, PCP or I don't know how it is with other people, but yeah, I tell them to see the PCP or pulmonologist. Yeah.
Sure.
To identify if it is actually or not.
Sure. Yeah. So in our primary clinic, what are the usual give points? If you have a classical case, yeah, you pick it up pretty good. But if they are not forthcoming in telling you all that, and our clinics are busy and stuff like that, anybody whose blood pressure is not getting under control, you have them on 2 or 3 antihypertensives and they're still hypertensive, right? Why is this happening? You look at the essential hypertension algorithm, and sleep apnea is one of them. AFib is happening, you looked into that, went down that rabbit hole and there's nothing there, so is that something to look at? Diabetes is not getting under control. So if all the multi-system consequences that are occurring and they are not getting under control, this sleep apnea is one thing to look into. So moving on to diagnosis. Now, we have some screening tools and they are pretty effective. Berlin questionnaire was a primary care physician clinic questionnaire that was developed back in the 1995, 98 era. Stop bang came about around 2008, which was more for a preoperative risk for sleep apnea. And then we do Epworth sleepiness scale on everybody. And then how do we proceed from there? By doing a sleep study, right, which is the gold standard. The in-lab overnight polysomnography is your gold standard to look for it. But if you do not have comorbidities and otherwise okay, you can get away with doing a home sleep study, which will be much less invasive, much less intrusive, so to speak. So methods to identify, we talked about the Berlin, the stop bang, the Epworth, the polysomnography, the home sleep study, and you can even do overnight pulse oximetry in these people. So if your pre-test probability is not that high, then you could start off with an overnight pulse oximetry, and if that shows you that they desaturated more than 12% of the night, below 88%, then that triggers a sleep study thereafter. So stop bang, the mnemonic kind of is something that one can remember. Snore loudly, tired all the time, apneic spells were observed by the bed partner, blood pressure is high, BMI is more than 35. In our cases, we could even drop it down to 30 if the symptoms are there. Age, neck circumference, and more so prevalent in the male gender. So I did a little modified movement effort, okay? I have not validated it. It is not used in any randomized control trials, okay? So, તમે કુરાન પડતા પડતા સૂઈ ગયા. What are the chances? Okay? તમે ટીવી જોતા હતા, મૌલાએ ના કહ્યું કે ના જો, લેકિન તમે જોતા હતા, સૂઈ ગયા પાછા. Okay? મૌલાની ઇંતજારીમાં બેસા છો, બેઠકમાં સૂઈ ગયા. લાઈન શરૂ થઈ ગઈ, બધા તમને ઉઠાડી રહ્યા કે ભાઈ જાઓ, મૌલાની કદમ બોસ ખાઓ. ઓકે, મસ્જિદ જઈ રહ્યા છો, ગાડીમાં સૂઈ ગયા. વઝુ તૂટી ગઈ, પાછા ગયા ઘરે. ઠીક છે, પાછા જમા પછી બેસા, સૂઈ ગયા પાછા. આમિલ સાહેબે બોલાયા કે મારા સાથે વાત કરો, તમે એના સાથે સામી સૂઈ ગયા. ઠીક છે ને, તો જમનમાં પછી સૂઈ ગયા. મુંબઈમાં ટ્રાફિકમાં સૂઈ ગયા. તો આ અલગ બધું અગર થઈ રહ્યું છે એન્ડ યુ આર સ્કોરિંગ હાઈ, that's requires a sleep study, right? Please આ કોઈને કહેજો ના મોડિફાઈડ મૂવમેન્ટ એક્સપિરિયન્સ. All right, so home sleep study, just a few quick things about it. So કોને આપણે કરવાનું? Basically those who do not have comorbidities. So anybody who does not have congestive heart failure, advanced heart, liver, renal disease, stuff like that. So any advanced comorbidities rules them out because there's just too much happening. You need more variables to really get into the nitty-gritty of it. So anybody otherwise, just a regular guy, 50-year-old, no comorbidities comes in and showing signs of sleep apnea. એ લોકોને હોમ સ્લીપ સ્ટડી આપણે આપીએ છીએ. You just hang it, refer them to the DME company. They provide them, it's a physician ordered devices provided for them. These are the basic parameters that we look for: airflow cannula, effort belt, oximeter, heart rate sensors. They self-apply it overnight. They return it back. The data is downloaded, sent to the physician. He reads it, and this is good enough to get your AHI, and once you have your AHI, based on that, you can start a CPAP trial. In-lab polysomnography for everybody else, anybody with comorbidities, anybody whom you think requires a little better feel of it, number one. Number two, anybody whom you think is a definite sleep apnea, all I have to do is get the number of his AHI, and at the same night, I will also titrate him to CPAP or to BiPAP. So you can do a split night study where half of the night is spent in diagnostics and the half of the night is spent in titrating the CPAP and the BiPAP. So you basically achieve both things at the same time.
Is that the most effective way
What else?
of getting the CPAP? Because normally we get the results from sleep study, and then they come back to us, we have to wait, and then refer back to sleep lab for
No. So अवे अपने नहीं करता because करता था. That was the way of doing things back in the early 2000s and in the mid 2000s. अवे अपने APAP आप ही दिया था. So now based on the HSAT, you give an auto titratable positive airway pressure machine. So the machine itself will determine while the patient is wearing at night what the adequate pressures are going to be. So you don't need to necessarily now titrate them in lab unless their AHI is so high and the respiratory disturbance index and all other parameters are so high that you actually have to see that the AHI has gone down while you're titrating them. So for the most part, you can get away by just prescribing an APAP to it. You give the settings on the APAP, high settings of 20 centimeters of water, low settings of 5, and the machine under tame nakido, it will play within that parameters through the night. Call them back about a week later, download that data, and figure out where they are hanging out in terms of pressures. And if the data is not congruent and the patient is still not completely asymptomatic, then you put them in the lab. Okay, so this is what we see, right? So this is an epoch so there are 30 epochs that we look at, and the software basically combines everything together and just spits it out. So for a sleep person who's reading it, it takes him about 5 minutes to go through a sleep study and determine what's going on. So this one is your EEG. It detects your alpha, delta, theta activity of your brain and looks at all the arousals, right? Now, if you follow this, when an arousal is happening just before the arousal, when the patient is sleeping, and everything is okay, the SATs are good, all right? But now a obstructive event has started. So airflow is stopped, all right? When airflow is stopped, because it's an obstruction, you still have thoracic and abdominal movement going on. छाती तो तुम्हारी चाली रही, सांस लेवा वास्ते, लेकिन कहीं ले नहीं सकती. So then you start paradoxically breathing. the abdomen starts coming into play. कि भाई चलो मैं तने help करूँ तू खींच हवा ने अंदर केम नहीं आउटी हवा, right? When this starts happening, the brain arouses up, brain wakes up. When the brain wakes up, it makes you like you go like that. When you go like that, the muscles tighten up, airway opens up, everything goes back being normal again, and you go back to sleep till the cycle. And then while that has been happening, you have desatted down to the 83%. People, and if you have morbid obesity, they can really take it down to the 50s, right? And once that happens, you go, your arousal thayu, pacha sukevai upar aavi gaya, and then this constantly repeats over the course of the night. Now, this is only obstructive sleep apnea. If you throw in congestive heart failure into this, then they will also have central sleep apnea. So then that condition is called mixed sleep apnea. So emasu thasa difference hu ase ama for residents, abi flat thiyas. All right? There is no movement. You are dead essentially. Central sleep apnea, you have not moving completely, right? Your chest is not moving, your abdomen is not moving, you're desatting. But the only thing that's saving you, that the brain will wake up and then stimulate everything to breathe for you again. So methods to improve sleep hygiene. Now this is a very important aspect of treatment of sleep apnea as a whole. It is just not about, okay, bhai, tamne sleep apnea hai, here's your CPAP machine, have a good day, or have a good night, you know. It is about doing what is called sleep hygiene. Apna ta bedroom is no longer a bedroom, right? Bedroom na andar TV bhi lagelu chhe, bedroom na andar lights bhi open chhe, hath ma phone bhi chhe, bazu ma bhi je chhe bhai, ena paase bhi hath ma phone chhe. So it's a constant, it's an activity room chhe ave. It's no longer a bedroom. So the idea is to create an environment where it becomes a bedroom, right? So tamne je bhi activity karvi chhe, TV karvu chhe, phone jo chhe, baddu karo, e baddu tamaru living room ma thayo. Now, when you are in the bedroom, within 5 to 10 minutes of lying down, the room needs to be quiet. The room needs to be dark. You have to tell your brain that you are going to sleep. Brain is, we underestimate what the brain power is, right? It needs to see the dark. It needs to see it needs to feel that we are about to go to sleep. But apne aji ena stimulate kariye che bedroom na andar, right? So when it gets so much stimulated, it doesn't know when to fall asleep. So खाली एक CPAP machine नाखवा से काम नहीं चले, आ बड़ी चीज़ भी करवी पड़से. So you have to have a consistent sleep wake cycle. अबे अपना में जरा थोड़ा problem है, right? But the thing is, if you're going to go to sleep around 10-11, then you need to go to sleep around 10-11. फजरी नमाज में उठवानु छे तो 8 time में उठवानु छे, right? So પછી રાતે પછી ચા પીને છૂટા, ચા ના પીઓ ચા રાતે. You are stimulating your brain. Don't have caffeine in the evening hours. Limit screen use before bed, relaxing routines, physical activity right before bedtime, and not a heavy meal afterwards. So all these contribute towards an effective sleep cycle. And on top of that, if you have a CPAP machine that is there, then altogether you have done a proper job at trying to go to sleep. All right, so treatment options. Duct tape hoy to use karo, vana agar na hoy, to pachi you need to do all this, all right? Dr. Gadiali spoke about this, so I'm not going to go into that. Weight loss, number one, okay? It will significantly improve everything, but it is એ બી ગલત છે એમ કહેવાનું કે તમે અગર વેટ લોસ કરી કાઢશો તો તમારું સ્લીપ એપ્નિયા ખતમ થઈ જશે. વેટ લોસમાં શું પ્રોબ્લેમ છે કે once you start, and especially the one slide I showed you about posterior wall per soft tissue accumulation, the tongue, the velum area, the tongue area getting bigger, that is not very responsive to weight loss. Once you get that, you kind of keep up the tube, right? તમારો આખો નીચેનો એરિયા જો સોફ્ટ ટિશ્યુ યા બળી જાય છે, it's not very responsive to weight loss. You will lose weight everywhere else, but not necessarily here. So the hope is that when you do have weight loss, it will help improve everything, but it's not a sure sign. So the whole goal is not to gain weight in the first place. Exercise, sleep position restriction. Now, there are people who, in the supine position, tend to have more occlusion. Some people do much better if they're lying on their sides. So if your sleep study shows that you have a higher AHI in the supine position, then some people have been instructed to, roll over, have a little bit of a wedge behind you, and roll over and sleep in a little bit of a reclined position, which helps remove that obstruction and improve the airflow. Positive airway pressure, I will speak about that in a minute. Oral appliances and other stuff Dr. Gadiali mentioned. So positive airway pressure. CPAP is the first line, but away we have, in the last few years, we just moved to APAP. Let the machine do the work for us, right? No, it takes out takes out the middleman, right? It takes out being in a lab. It takes out the technician scoring the CPAP and everything. So just give an APAP machine. So the only thing I do is I give the upper limit to the pressure and a lower limit to the pressure, and the machine is so smart enough that it will figure out where it needs to be. So on a breath to breath, it is able to sense how much pressure is needed to overcome the obstruction. And BiPAP is meant for those people who, so especially in the patient population who also have concurrent obesity hypoventilation syndrome, because now they have daytime hypercarbia. So they actually are not ventilating at all. So it's not only about splinting their airway open, it is also about getting that carbon dioxide out. So for those highly high pressure cases or obesity hypoventilation cases, then you kind of prescribe them BiPAPs. So अभी एक जो concept patients have indicated okay, you are going to force air into me. You're not forcing air into you. You are taking air okay at times. You are just trying to splint your airway open. So the airway, once that pressure opens up your airway, the air movement is not the bigger problem here. It is just how much pressure do you need to create a pneumatic splint to keep the airway open and prevent the tongue from falling back, prevent the soft palate to collapse on you and stuff like that. So the CPAP delivers one fixed pressure all night. APAP, as I said, adjustable pressure breath by breath. BiPAP for high pressure situations. And then very rarely do we have to get into this adaptive servo ventilation, and I'll ignore that for now. So at the beginning of the talk, as I said, it's a mechanical problem. You take care of the mechanical problem, everything lines up after that. It's as simple as that. So itlo faido evi koi cheez ma nathi in my as far as I know in medicine, tame diabetes ma metformin apso lekin metformin bhi titrate karyu padse badu karu padse, right? Everything else takes its time, but you remove the mechanical obstruction and everything just falls into place. Humans were not designed to wear a mask and go to sleep. It's right? So now over time, you have different interfaces that you can use, right? So you can start off with nasal pillows. You can start only with the nose interface, a nose-mouth interface, or a full face interface that we use in the hospitals. It all comes down to what is tolerated by the patient, right? So there's no one size fits all. So ema jara thodu karvu pade. Mask ek bar leakage. So they have to be careful about ke kitlu tight. Agar bhare tight kar se to muh par rakha, nishan ho padi aisa. Agar bhare thodu kam ban se to leak factor, and that is something that the APAP machine is very good about. It even gives you the leakage factor, so you know ke is it the pressure problem, or is it that the mask is just leaking too much? Most important in this is education. So the first visit, one of two things happen in my clinic. Either the patient comes back and says, it's a change of night and day for me. I haven't slept like this forever. This is the best thing ever, and you are going to be in the who's who of doctors for me. And some will come back and say, I threw it away. I just could not tolerate it. I just threw it away. I called the DME and he took it away. I'm like, why did you take that step to call the DME and take it away? You could have just called me up and we could have talked about this. So some people will just throw it away. And some people will, as soon as they go to sleep and they feel good about it, they swear by it. And then they become actually your advertisement for other patients to use it. So how could you make this work? Mask lasate, you play around with a few masks. Basically, the DME companies are good about giving them 2 or 3 masks to play with for the first few days, see which one works better for them. You humidify to prevent all this dryness in the nose and mouth. again, back and forth coaching with, with your clinic nurse as to, hey, this can work, this can try this way, try that way, that kind of thing. And then more importantly, and this is also required by Medicare and everything, that you have a 3-month follow-up to download the data to see whether they are, A, they are using it right, it's working for them, and B, whether Medicare will continue to pay for it. In some patients, this is also an oral appliance is added on, so bring the mandible forward and then apply a BiPAP or a CPAP machine on, so that improves tolerance as well as efficacy. So again, I will skip through this and just show you a picture as to how it happens. So થયું શું છે કે ટંગ પાછળ પડી ગઈ, soft palate બી આવી ગયું પાછળ, તો the airway completely closed up. So now when you are wearing this mandibular device, it pushes, it brings the mandible forward, brings the tongue forward, and the air opens up, right?
Are these custom fitted or?
They are custom fitted, yes. Yeah. And then hypoglossal nerve stimulation, Inspire, as Dr. Gadiali mentioned in much more detail as to how that works. So this is just the stuff I wanted to talk about. So the key takeaways is sleep apnea plus CPAP machine will win the race every time. The biggest takeaway from this is that sleep apnea, undiagnosed sleep apnea, is going to lead towards increased mortality and much other organ system failures than we recognize. Right? Thank you. All right.